Okay, I think we'll get started. Hi, everyone. I am Larissa Mooney, and it is my pleasure to introduce our Grand Round speaker today, Dr. Bryson Lochte. Dr. Lochte earned his MD from the University of California, San Diego, and completed his psychiatry residency at UCLA's Neuropsychiatric Institute. He has pursued additional training in ketamine-assisted psychotherapy, psychedelic-assisted therapy, and internal family systems. Dr. Lochte currently serves as an attending psychiatrist at UCLA's partial hospitalization and intensive outpatient programs, as well as in the UCLA Addiction Psychiatry Clinic. In addition, he maintains a private practice in Santa Monica, where he integrates medication management, experiential psychotherapy, and ketamine-assisted psychotherapy. So it is wonderful to be welcoming one of our former clinic residents who has gone on to attend and teach in our addiction clinic and apply some of his unique skills to the management of co-occurring substance use and mental health disorders. I'll turn it over now to Dr. Lochte.
Thanks so much, Dr. Mooney. So today I'll be talking about ketamine-assisted psychotherapy. I hope you guys find this to be an interesting talk. I think that this is an interesting subject because, we think a lot about psychedelic use in treating mental health conditions. There's just so much enthusiasm right now for this, but when viewed from an academic perspective, it's hard to make sense of what's the signal and the noise in terms of this enthusiasm. But I think we can look to ketamine-assisted psychotherapy, where there's a lot of work being done trying to really determine what are the best practices, the ways that clients are best benefiting from these new tools. I think this is the best place to kind of evaluate that and get a good picture of it. I think hopefully, what this talk is going to be is not so much looking at the data and, the research on ketamine, even though that's very important. I think with a shift this big, something where you're really changing possibly the field of psychiatry and how it's being practiced, we really need actually a change in the culture and the community as a whole. And I think that really incorporates the knowledge from experts in this field, people that have been working with these kinds of tools and learning a lot from the clients that are actually being treated in this way. So that'll be kind of my perspective today. I don't have many financial relationships to disclose. The content in this presentation is based on my personal clinical experience and opinions. It doesn't necessarily reflect the established evidence-based guidelines or consensus recommendations. And I think that's kind of, a big theme of the talk is that there really isn't any consensus guidelines for how to do ketamine-assisted psychotherapy. It's something that's kind of emerging from the community of people that are doing this type of work. And right now I wanted to just start with kind of what my journey has been like in learning how to do this type of work. And that started in residency. I was really interested in doing psychedelic type psychotherapy. And I was part of the psychotherapy concentration, and I sought out Tom Broad as a supervisor. He's a really brilliant psychiatrist and psychoanalyst who does ketamine work in his own private practice. So he was my supervisor in the 3rd and 4th years of residency, and he really showed me the ropes, or at least sort of taught me in general how he does ketamine-assisted psychotherapy. And I came to him sort of asking, how do I sort of get involved in this work? And he told me I should do some sort of formal training in this type of work, and that's where I met Phil Wolfson. I did ketamine training with Phil Wolfson. He's got the Ketamine Training Center, and he does these ketamine trainings. He's one of the leading experts in the use of ketamine for ketamine-assisted psychotherapy and the use of ketamine in mental health conditions. He wrote the book, The Ketamine Papers, and a lot of how I view ketamine in my model is based off of doing this training with Dr. Wolfson. It's also an experiential training. As part of it, you take ketamine, you get to experience what that's like. And I think one thing that I've learned is that being able to do your own work and sort of understand the terrain of expanded states is a big part of being able to support people through this journey as well. The next training that I did was through MAPS with Michael and Annie Mithofer. If their names aren't familiar to you, they're sort of the leading the edge in terms of psychedelic psychotherapy, doing clinical trials in this field, especially relating to MDMA for PTSD. They're really looking at what are the most safe and effective ways of implementing these tools. And after doing these trainings, I was really interested in, directly applying this, working with real clients. And so I joined a group, a small ketamine clinic or a ketamine clinic in LA or in Santa Monica called Home LA. It's headed by Eva Altobelli, who's an addiction psychiatrist. And she really helped me learn the ropes of how to do ketamine treatments. I started there just by doing medical evaluations and prescribing ketamine troches for therapists in the clinic to use and do the actual treatment sessions. But I moved on to starting to give IMs and supporting the therapists in the treatment sessions. And then when I felt comfortable, I started doing IM ketamine treatments on my own. Eva's a really amazing person because she's a great connector of people, and she's really kind of a central hub of the ketamine movement or people that are working with ketamine. I met Raquel Bennett, who's a leading voice in ketamine research through Eva. And then I also was introduced to this amazing community, Big Tent Ketamine, which is a collective of practitioners with all sorts of different backgrounds. It's a grassroots online movement of all these people who are collectively working together to try and figure out what are the best guidelines and ways of using ketamine in therapeutic work. We did a meetup, and that's where that picture was taken. But this has been a really invaluable community, and something that if you're interested in doing ketamine work, I'd really encourage you to get involved with. And then, finally, so after I felt comfortable, I was doing ketamine treatments on my own. I went off to begin my own private practice in Santa Monica. And mainly that practice is focused around psychotherapy, weekly psychotherapy, but I also implemented ketamine-assisted psychotherapy as a tool there. I'm still learning a lot. I feel like at this point, I have a pretty good understanding of how to carry out a ketamine-assisted psychotherapy session. I've probably done about 100 of them in my practice so far, but the work of learning how to work with people in expanded states of consciousness is something that I'm still learning a lot about. And this is a really growing field. How do we do this appropriately? And nobody knows more about this than Stan Grof, who is a personal hero of mine. I had a chance to meet him recently, and if you don't know his name, he's a really important person to read his works if you're interested in psychedelic psychotherapy. He's kind of the father of that field in general. And you can start with his books, The Way of the Psychonaut. So yeah, I'll talk a little bit about just the history of ketamine. So it's a pretty interesting history. It sort of starts actually, the father of ketamine is really phenylcyclidine, or PCP. After this was synthesized, it started becoming used as an anesthetic because it was able to block pain without decreasing respirations. But it had this side effect of creating, psychosis and agitation and delirium. So there was a strong effort to try and find another substance that was similar, but that didn't have these negative side effects. And that's how ketamine was synthesized. It first became FDA approved in 1970s as an anesthetic, and it went into pretty wide use as a battlefield anesthetic in the Vietnam War. At that point, and then still today, it's used in anesthesia pretty commonly in emergency rooms and burns and pediatric anesthesia, as well as veterinary medicine. There's also a really important story in its global use. Since it doesn't require a respirator to use ketamine, it's oftentimes used as the first line anesthesia in middle and low income countries. And it's considered one of the World Health Organization's essential medicines. It's really widely used, and it actually is the main anesthetic for about 2 billion people globally. I like to just keep in mind that history as we talk about ketamine for mental health reasons, because it kind of helps me feel more reassured. When we think about it in mental health use, it sort of feels like this thing that's new or kind of unknown, but there's actually a long history of the use of ketamine, safe use of ketamine. We really know its safety profile, and that kind of helps me feel a little bit more reassured when working with it in psychiatry. Also, its use in anesthesia as a dose is much higher than we would ever use in psychiatry as well. And those doses have been shown to be very safe. In the 1990s is really when we first started seeing clinical reports of its rapid-acting antidepressant effects. By 2010 is when you started seeing a lot of IV ketamine clinics start springing up around the country. And then the recent history has been punctuated by all these FDA approvals for esketamine for treatment-resistant depression, with the most recent one being earlier this year for treatment-resistant depression as a monotherapy. So I won't get too much into the mechanism of ketamine. I think the main thing to keep in mind is that it acts throughout the, pre and post synaptically at various areas in the receptor or in the synapse, and it modulates glutamate. This is a really novel mechanism, both for its rapid-acting antidepressant effects. This has spawned a large area of psychiatric research for similar compounds that act in this way. But also, it's a novel mechanism in terms of its use as a psychedelic. Since it doesn't work in the serotonin syndrome, or it doesn't work in the serotonin system, it's safe to use with antidepressants. You don't have to stop antidepressant medication if you're starting the course of ketamine. From a neuroscience perspective, what we think about in terms of the effects of psychedelics or a substance like ketamine is that it starts to create a disruption in the default mode network. I like to think of the default mode network as holding the models formed from our life experiences, and these models are used to basically interpret sensory data to make sense of it and turn them into our perceptions and expectations. When we disrupt the default mode network, we kind of open up this model and allow for sensory data to kind of exist in its raw form for a little bit longer. And we also, theoretically are opening it up to a space where you can incorporate new models that are a little bit more corrective or a little bit more healing, that are more accurate and beneficial for how we view ourselves, others in the world. The other thing to keep in mind is the window of neuroplasticity. What neuroscience has showed us is that after a dose of ketamine, there's a period of new neuronal growth, dendritic branching that occurs 24 to 48 hours after a ketamine treatment. This probably stays open to a lesser degree afterwards, but this period is very important clinically because we really want to use that to incorporate new insights, beliefs, and narratives that might come up during the ketamine session. Yeah. Yeah, so for example, you might want to maybe do a follow-up appointment the day after a ketamine treatment or 2 days after the ketamine treatment, or if you can't schedule a follow-up, you really want to kind of think about what you're going to do for that day or two after a treatment and not just go right back into regular life that's, with its stresses and issues. From a more psychological perspective, I think a good way of thinking about ketamine treatments is with this term peak experience. Essentially, this peak experience is a term coined by Abraham Maslow, who's most commonly associated with the hierarchy of needs. And his idea was that, throughout life, whether it's summiting a mountaintop or the birth of a child, you have these certain experiences that really open you up. They're momentary and they're intense, but they're very profound because you sort of, for just a brief period, transcend your own identity and your own self-consciousness. And in my view, this is sort of what the aim of the ketamine treatment is to do, is you want to try and open up to some kind of experience like that. He describes it as being simultaneously more powerful and also more helpless, great ecstasy and wonder and awe, the conviction that something extremely important and valuable had happened. The subject is to some extent transformed and strengthened even in his daily life. And these are sort of some of the terms that people describe. This is how people describe ketamine treatments after they're done, is they're kind of these very significant moments in their life, even if they can't really articulate how that happened. They do seem to be sort of peak experiences in people's lives. I think another really important concept that I oftentimes think to when doing this type of work is the idea of psychological expansion and contraction. I think this really gets to the core of kind of what the paradigm shift is in psychiatry right now. In general, probably for the most part, we want to be existing on this side of the spectrum, the contracted side of the spectrum. This is sort of the mental structure that we have to get work done, to drive our cars, to do taxes. Abraham Maslow says that this is what we would call a plateau experience, meaning this is something that, it's where you put in concerted effort to sort of cultivate a sense of fulfillment that's aligned with your values. It's something that's extremely important in life and important for doing things like caring for others and getting things done. But But you don't want to just live in a contracted state of mind, especially in terms of relationships. If you're interacting, playing with your kids or something like that, you don't want to be in a work mode. You don't want to be in that contracted state of mind. You want to have a little bit more spontaneity and some creativity. And so it's important to kind of foster an expanded state of mind as well. The point is that it's not that one side is better than the other. You probably want to be contracted for most of your life and then occasionally be able to expand your state of mind. But the key is that you really, in a healthy individual, you want to be shifting through these two different poles depending on what kind of environment you're faced with. Um, yeah, and I think the main thing here is that for the most part in psychiatry, our drugs and our medications are moving people more into a contracted state of mind. You think maybe about stimulants kind of helping people fit in with their environment, or antipsychotics or mood stabilizers help move people into that way that they can function in the world and behave appropriately. But I think that that's neglecting sort of this other side of the spectrum. I think, certain types of therapy kind of move people more into an expanded state of mind, things like dream analysis or pre-association or experiential psychotherapy kind of foster this expanded state of mind because what they found is that these expanded states are very important for doing deep healing work, really resolving core issues, core traumas. It's very important to be able to be in these expanded states because it's not really possible to heal from a contracted state. You really need to be in a little bit of a regress state to heal these deeper traumas and wounds. And I think that's why people are drawn to psychedelics, is because psychedelics induce these very expanded states of mind where that deep healing is possible. I think there's a danger with that too, because this is also where theoretically psychosis exists, acting out, dangerous behavior, sort of unstable psychiatric conditions are also in these expanded states of mind. So I think the key here is like, how do we benefit from these expanded states of mind, but then also bring things back into a contracted state of mind? And that's why the therapeutic container is so important. You want to be expanding within a safe context, and then you also want to work on bringing things back into contraction afterwards. So, one second. Um, so in this next part, I'm going to talk a little bit about how to actually do a ketamine-assisted psychotherapy session. The main thing that I want to emphasize is really how do you build this therapeutic container around this experience? A term that I really like is that we like to move at the speed of trust, meaning that you don't want to be rushing this process. You really want to make sure that the client is comfortable with the environment that you're setting up for them or building with them together. So this also means that you're tailoring a lot of this process to what the client wants and needs and what they're coming in with. For me, since I oftentimes am doing therapy with the client, the preparation phase is something that I can really stretch out and get a lot of value from doing that with. But I think that's not always possible, but I think you still want to kind of give the preparation as much time as really they need to feel comfortable with what they're stepping into. The experience itself, I think you can also vary the number of sessions based on what the client is looking for. If someone is, doing in a therapeutic process that's going pretty well and they just want to kind of have explore a new area of the self or move things forward in a way that might be interesting, then you might only need 1 or 2 sessions of ketamine-assisted psychotherapy, and that will work well for them, and they can kind of mine and integrate those those experiences for a very long period of time. If you have someone that's coming in with more of a medical model, they have treatment refractory depression, they have this DSM diagnosis, and they really want it to be treated in a medical type model, then you can say, well, maybe we should do 4 to 6 treatments. That's kind of what's recommended from the data. And maybe we can do the, 2 treatments per week, kind of condense the treatments based on, what's been shown by the research to be effective for that condition. For other character, if people are really trying to do deep character change or big processes within their personality or resolve deep, long-standing trauma that's very complicated, you might want to stretch the treatments out a little bit further. maybe 8 sessions or 10 sessions. I really have a strong cutoff at around 10 or 12 sessions. I don't like going on with extended treatments because I think at some point you just have to consider the course closed and then move on to the integration process. It's very important to kind of balance these expanding sessions with long-term integration after. You might be able to do another course in a year or two, but you don't want to go on for sort of perpetual treatment cycles. Yeah. So the first place to start is the safety screening. You want to do a good evaluation of each client that comes in for this type of thing. From a medical perspective, ketamine is generally fairly safe. The main issue that you see is that there's a transient elevation in blood pressure. That's about 10 points systolic, which is kind of equivalent to an hour or so of heavy weightlifting. And you just want to think about which clients are, can handle that kind of thing. Anyone who's got severe cardiac disease, unstable hypertension, or uncontrolled hypertension or unstable angina, arrhythmias, these are things you want to be concerned about. You also want to be wary that there can be an increase in intracranial pressure and interocular pressure. So you want to be careful of things like AVMs, hemorrhages, glaucoma. And then you also want to screen for pregnancy and obstructive sleep apnea, especially if you're getting into higher doses of ketamine. As far as psychiatric screening, you just want to think about, you're moving into this expanded state. It's possible that you could kick off a period of psychosis if someone has an underlying diagnosis or even a period of mania. It's probably not impossible to work with people that have bipolar disorder in the ketamine context, but you want to make sure that they're on appropriate mood stabilizers, and that would be kind of up to the provider's comfort. Substance use disorder, some people consider this a contraindication. I actually think that there's a lot of potential benefit for ketamine use for substance use disorders. I've never personally used it for that indication, but in people that I've treated, I've seen that they just naturally will reduce their use in substances or kind of come to the point where they realize that they need to quit a substance. So I actually think there's a lot of potential value there as a tool in substance use disorder. But I would say with the stipulation that problematic psychedelics use or problematic ketamine use is probably more of an absolute contraindication. Also, people that are in sort of an unstable recovery period, this is, a drug of abuse, and it's also, an intoxicant and euphoric, and you could maybe kick off relapse theoretically. Some other considerations that I keep in mind, these are sort of more softer considerations and not necessarily that people can't do ketamine treatment, but just that it might not work as well, or maybe that they need a little bit more time within a therapeutic context before they jump right into ketamine. The first one is just you want to sort of look at them internally. Within the client self, do they have a sense of safety within themselves? Are they able to ground themselves if they start to get panicky, or do they really need regulation from you as a provider? In a ketamine treatment, since they're going off into their own world pretty much, they're going to be kind of on their own in that space. It might be hard for you to ground them. So you want to make sure that they have some ability to self-regulate. I think certain personality features like extreme rigidity, where they really have a very concrete view on how things are going to be working or what they need, that can be a little problematic. You can actually get some really interesting effects when you treat people in this way, where they'll start to have really profound insights and really big breakthroughs or seeming breakthroughs in the ketamine treatment. But then within 30 minutes or an hour, oftentimes that rigid viewpoint kind of comes back together, and they don't really experience a lot of the benefits or new ways of seeing that might be coming through from the ketamine treatment. Also, people that are very externalized are not really capable of too much internal reflection or understanding how their internal world is influencing the patterns of their life. Those people might not benefit as much, and just generally people that are coming in with a little immaturity around the process, not full understanding or respect for what the process is. That's something that's also a bit of a red flag. You might see people coming in who kind of at baseline are living in a more expanded state of consciousness, that's something that you want to be a little cautious of, and especially people that are kind of moving around from different journey experiences, like one to another, like doing ayahuasca like 2 months ago, and then psilocybin a couple weeks ago, and then they're doing a ketamine treatment and then an MDMA treatment after. You'll start to see some of these people, or at least I've started to see them since I started offering ketamine. And I think that this is a pretty common thing that's emerging in Los Angeles in particular. And oftentimes these people really do need help. They're trying to resolve an issue. They're not just, drug seeking necessarily. They're really trying to work through something that's happening internally, and they're really fixated that they need to be working through this using expanded states of consciousness. But I would really recommend, if they're open to it, sort of explain my thinking on it, but that they really need kind of help actually going back into a constricted state of mind and integrating some of the experiences that they already had in a relational container. I think that's the third consideration, is that you really want to make sure that people have some respect for the relational container, that they're kind of agreeing with this idea that you need to build the trust together. And if they don't really see the value in that, that's often a sign that they're kind of numb to their own feelings, or that they're pushing themselves into this process somehow. And this is just all signs that you kind of want to slow things down, or maybe try other options before going to ketamine. I think ketamine is a great entry point into the world of like substances that can induce expanded states, because it's very gentle and can be easily titrated. But before you even think about ketamine, you can also think about other activities that can be used to explore expanded states, even things like experiential psychotherapy, like isolation tanks, breath work, holotropic breath work, body work, somatic experiencing. These are all sort of gentler ways that are easier to titrate into that form of healing. Some external considerations: you want to look at the world that they're going back into. One thing to keep in mind is that with the ketamine treatment, you can often get things kind of moving in the worst direction before it gets better. And especially with people that have suicidality, or maybe have a history of hypomanic episodes, you just want to maybe connect with some people in their support network that can kind of keep an eye on them after a treatment. I've honestly never seen those things become an issue after a ketamine treatment, but I definitely see people kind of coming out of the treatment very raw or tender or sensitive for a few days afterwards. So you want to keep that in mind. And you also want to look to make sure that their life actually allows for some form of change. You might see this in like adolescents that are being brought in by their parents. If you're kind of feeling like maybe there's an issue with the family dynamics rather than with the adolescent themselves, you can try and open up their system. But what you'll find is that, if you open up their system and then they go back to this problematic environment, then their old mode of being will just reemerge, that mode of being is actually very necessary, and that they're not really in a place that can sustain that change. It's not friendly to that change. I think if you're trying to find like an ideal client, I would say it's someone who's pretty well regulated and responsible, sort of open-minded and reflective as well. You want to think of someone that's kind of more stuck on that constricted side of the spectrum, that's maybe having trouble accessing more expanded states of being, like someone who's generally got a pretty good life going on and feels like that maybe they should be enjoying their life a little bit more, or living more in an open-hearted or expressive way, but is just struggling. They just don't feel like they have access to that part of themselves. You often see this in sort of parentified child type archetypes. Yeah, so I think those people really like, it's almost a guarantee that they're going to benefit a lot from this type of treatment. As far as preparation, you think about the classic set and setting. Set as mindset. This is where you want to explore expectations, concerns, patterns. You want to give them information. Even a lot of the information that I'm presenting here is helpful just to help people's systems relax into this type of experience. You want to normalize anxiety. You can be anxious going into this type of experience as well. You don't have to be, that's sort of okay. And then right before the treatment, you might want to do a guided meditation to kind of just help them bring their attention inwards before going into one of these experiences. As far as the therapeutic setting, the main thing is developing this container, this thing that I keep talking about. You really want to mold that based on, the client, how the client is sort of thinking about things. You also really want to have a clear consent process and a thorough consent process for this type of work, because you don't want to be doing that when someone is in a session. This is especially true around how they want to be supported in a session and especially how it relates to touch. With these expanded states of consciousness, what we sometimes see is that people will start to regress. They'll regress to periods in their lives, and they'll maybe start grappling with traumas of omission, periods where they weren't held or supported as a child. And sometimes what they really need at those moments is some sort of physical support, whether that's like a hand being held or a hand on the shoulder, nothing too crazy, but it can be very meaningful to have some physical touch in these deeper experiences. And that's something that you want to get explicit consent with before you start, if you feel comfortable with that kind of thing. Another idea that's really important is the concept of the inner healing intelligence. This is a term coined by Stan Grof, and he was one of the first people to do psychedelic assisted psychotherapy. He was working with LSD, and he's a Freudian analyst. So he first started by doing low dose LSD and attempting to do analysis with the patient. But what he found is that it was a much more effective just to give them the LSD and then just ask them to put on a blindfold and just be aware of their own experience internally. That the outcomes were much better. And he made sense of this by coming up with this idea that we have this innate capacity to heal ourselves. And this really shines through when you're in an altered state of consciousness. The mind will just take you where you need to go. This is kind of a challenging idea for therapists because the therapist no longer is the therapeutic agent. They're just sort of supporting this process, and the client is really the one or the client's subconscious is kind of the one that's healing themselves. It's also something that the client has to trust too, because there's going to be a lot of ambiguous information, esoteric stuff that comes up that is difficult to interpret, and the client just has to trust that, they're in a new terrain and they have to build a new relationship with this terrain. Even though it seems confusing, you have to trust that that is coming up for a reason. This is also, this is also true for difficult experiences too. Difficult experiences can arise. I mean, for the most part, ketamine treatments are generally fairly relaxing and blissful. They're very powerful, but they're generally very pleasant for 70% of the time. Difficult experiences emerge probably 20 or 30% of the time, I would say. And this can be feelings of panic or confusion, maybe feeling stuck, maybe having some traumatic flashbacks come through. Sometimes people even feel like they're dying or that they're going to be going insane. And when this comes up, you want to first talk with the client, let them know that these kinds of things can come up. And then when they come up in session, you really want to encourage the client. Well, hopefully the client should kind of know to do this, but the idea is that you want to be leaning into these experiences, that they're coming up to be processed. Really, the whole point of this ketamine treatment is that you're opening up a stage for material from their unconscious to emerge, and then you want to witness that material. You want to lean into it. It's kind of like when you're in a nightmare where you're being chased by a monster. If you keep running away from the monster every time it pops up, you keep having the nightmare. But if you can turn around in the dream and face the monster, then the nightmares stop. Stan Grof says the full expression of a negative emotion is the funeral pyre of that emotion. And I think that's exactly what he's referencing, is that if you can actually face these emotions or these feelings that you feared, then that's the way to work through them or eliminate them. So in sessions, when people have emotions come up, you really want to encourage them to actually make them bigger. And this can be sort of in a cathartic expression as well. So, whether that be kind of crying or shaking or feeling extreme fear, sometimes anger can come out. People feel like they need to yell or punch a pillow. So maybe nausea, they might feel like they need to gag or vomit. You really want to explicitly say that these types of things are okay, and trust that they're, these things come and then they pass, but it is very powerful to actually allow people to have or touch that kind of experience and go into it. People will start to run into more challenges when they try and turn away from it or repress it or feel like it's not appropriate to do in the session. That's when you can kind of get stuck in a certain place, and that's oftentimes makes the experience much more difficult and less beneficial. If you're having trouble moving through an experience, you can also encourage them to focus on their breath or talk to you or tune in with the music that's playing in the room. A difficult experience is not necessarily a bad experience. In fact, it's kind of the opposite. If you can have difficult experiences come up and you can move through them appropriately, then they can often be the most healing and meaningful experiences as well. Before someone goes into a ketamine treatment, I like to do what I call the launch instructions. This starts with just 3 basic agreements, not for them not to harm themselves or others, to not leave the room until the session is over. And this is for the client and the provider, is that everyone in the room is going to be respecting the word stop. I like to use the metaphor of a roller coaster that within this journey, even though it might be scary or make a lot of feelings come up, in the back of your mind, you can kind of remember that this is a very safe process. We know exactly, how long this is going to last. 1 million people have done this before. And at the end of the day, you're going to be right there, or at the end of the hour, you're going to be right back where you started. You also just want to encourage them. There's not really any right way to do this, that they've made a really courageous gift to themselves by giving themselves this experience. And if they can just let go of any expectations or intentions and just trust the process is going to be beneficial. You kind of want to encourage them to maintain an internal focus and just lean into what's emerging. And then just remind them that they can express themselves if they want to or need to, or if that urge is coming up, that's not something they should fight. That's something that they should allow to kind of flow through. So this is what the treatment itself looks like. It's someone lying on the couch with blindfolds on, just a comfortable position. Before you start a treatment, you want to invite them to go to the bathroom, because sometimes fixed ketamine can kind of make people need to urinate. You want to get a set of vitals before you start treatment, and then maybe give as needed medication if that's indicated. There's a lot of different modes of delivery for ketamine. The kinds that I use in my practice, primarily I actually just use IM dosing, a shot in the shoulder. And when you give ketamine this way, it's a pretty intense experience, because it's not just the dose of the ketamine that creates the subjective effects, it's also the rate in which it enters the system. So with an IM, you get the ketamine you'll start to feel a little bit of an effect at 2 minutes, and then you'll get a peak up to its full effect in about 10 or 15 minutes. So you get a really rapid rise. And then the remaining 30 or 40 minutes of the session is kind of a gentle plateau downwards, or a gentle slope downwards. Determining the dose is something that there's a lot of discussion about, whether you do booster doses, things like that. It's very much kind of an art. It's not really a science at this point. In general, in my practice, I'll do sort of a standardized small dose as the first treatment session, just to kind of see how the client system responds to ketamine. And then after that, we can sort of work together and have a discussion about what, how far out they want to go, what they're kind of trying to work on, what might be too much if they have concerns. And then from there, we work together to kind of decide what the next doses will be. Ideally, you're looking for kind of a sweet spot where they're having big, powerful experiences, but also experiences that they feel like they can integrate well, and experiences that aren't too much for them. You don't really want to be re-traumatizing them through this process, and that's something that could theoretically be possible. In the experience, you really want to just continue to encourage them to remain internally directed. And then you also want to be playing music. Music is really helpful for evoking associations that are often helpful for healing, and kind of just guiding people through sort of a movement through the journey. All right. So there's a whole range of different experiences that people can have on ketamine. I like to think of them in terms of low, medium, and high dose experiences. Low dose, I would say, kind of falls in the range of 0 to 30 or 40 milligrams IM. And this is really similar to maybe a few glasses of alcohol or a benzodiazepine. You kind of just get a mild inebriation, some dreamy thinking. Sometimes, there can be sort of an interesting conversation that flows at this dose range. Medium dose begins at maybe like 40 milligrams to 80 or 100 milligrams. And this is where you really get sort of the psychedelic effects. You start to get visions or somatosensory sensations, feelings of floating in space or twisting around. And sometimes deep memories can start emerging or feelings of kind of regressing to different ages. This is also where it starts to become difficult to move or talk. So you really want to make sure people are staying within during this time. High dose is like, I would say, 80 to 100 to maybe 120 milligrams plus. And this is where you start to move more into really transcendent type experiences, more spiritual experiences. And, if they're good, if they're kind of bad, sometimes people can, or not bad, but this can also kind of feel a lot like death as well, death type experiences, which can be very powerful and healing, but can be very frightening if someone's not ready for them. This is sort of where you would think about the idea of a K-hole, where, because you're also very disoriented in high dose, with high dose ketamine. You really, if you wanted to get up, you really couldn't get up. If you wanted to take off your eye shades, and to orient you, your eyes might have trouble focusing and you might be very disoriented. You might not really be able to talk or articulate yourself in a high dose experience. So you're kind of just along for the ride there. And if you can lean into that and that's something that feels safe for you, then this is enormously powerful to work in this dose range, but it's also something you don't want to throw people into if they're not ready for it. I was talking to someone who had done a lot of work with ayahuasca and other psychedelics and thought ketamine was going to be very straightforward, and ended up getting a high dose ketamine experience, and was taken to a place that he was entirely unfamiliar with, and very, it was a very frightening space for him. And it took him, a month or so to kind of process that experience. And it, in a way that was semi-traumatizing, a bit more than he bargained for. And, I think that's what I think about with the high doses. You really don't want to accidentally push people into a high dose experience if they're not ready for it. Because that's a lot. These images on the right side of the screen are just, these are sort of different things that clients have described to me in the ketamine experience, ways of sort of describing their visions. I think ketamine has a really interesting flavor. A lot of people describe these very intricate, expansive, complex environments that they're kind of moving through or floating through. But they're oftentimes very empty. There's not a lot of creatures, with DMT, you think about elves, or ayahuasca, you think about jaguars and snakes, but DMT seems very empty. It's sort of death theme, spiritual theme, floating through space. But there is this kind of feeling of profoundness, but also kind of emptiness too. I'm not sure what to make of that, but that's just what I've seen. I just wanted to talk briefly about some worst case scenarios. I've never really had any bad outcomes from any of the ketamine treatments I've done. Sometimes people take a little longer to come out of it, in which case I like to keep my waiting room available for people to take it easy for an hour or two, or however long they need after a treatment. But this is some stuff that I've heard about, talked about on Big Tent or from my own research. One is the idea of a laryngeospasm, which can happen in anesthetic uses of ketamine, where people are transitioning between different states of consciousness. You can get a spasm of the larynx, and the treatment for that is this thing called the Larson's maneuver, where you apply pressure to both sides of the jaw to open up the airway and push the jaw forward. It's also kind of painful, and it sort of snaps people out of that state and relaxes the larynx so that they can start to breathe again. If people are still having trouble breathing, one thing that ketamine can do is potentiate the effects of opioids. So there have been cases of people using the regular dose of opioids after a ketamine treatment and then overdosing. If someone's really not breathing, it's not the ketamine that's doing that. It might be that they have opioids on board that are being potentiated by the treatment. So I do like to have Narcan available. I think the biggest risks are really people trying to drive after a ketamine treatment. So you want to be very strict about them getting rides to and from the treatment. And then falls. There have been some fatalities around falls when people use ketamine at home. So you really want to be careful about that because people oftentimes need to get up and go to the bathroom during or right after the treatment. So it's nice to have a walker or a cane or really help them in that process. You want to be mindful because it's not just that their legs might not work, but they also might not be able to work their arms to be able to catch them if they're falling. So you can get pretty bad falls. Let's see. So next is integration. Integration. So the first hour of the treatment session is kind of prepping, doing the vitals, and sort of easing them into the process. The second hour is actually giving the ketamine and sort of sitting for them in that state, holding the space. And then the final hour is going to be where you start to make sense of what they experienced and begin to move into the process of integration, which is sort of an ongoing process after a treatment. I think integration is hugely important because I think this really determines whether or not the treatment has temporary effects or whether it has permanent effects. If you're not integrating and you're not making actual changes in your day-to-day life, then I think then the treatment is probably only going to have temporary benefit. Really, you want to kind of see what the treatment did in terms of shifting your own values, and then you want to support those shifts with conscious effort. It's how you weave the mystical with the practical. If you think about the tree, the tree can only grow up as much as it can, as far as, based on how well it's rooted into the ground. And that's kind of the idea with integration is that you can try and go up, but unless you're kind of grounded in your day-to-day life, that can't really be supported well. It's not an easy process. This is kind of like homework. You have to actually do the work here. And a lot of clients will sort of squirm away from it, but you have to really emphasize how important this process is. So here are a few examples of integration. Generally, you want the client to guide the integration talk. You want to say, what did you experience? What do you really want to take away from this experience? And how concretely can you bring this into your life? And see what they say. Oftentimes they have answers to those questions, but if they struggle with that, I like to sort of think about the themes that came up in their session, and then I, think of integration examples that kind of might support those themes. So if they're dealing with issues in the body, you might consider body work or dance. If they're dealing with sort of thoughts or kind of mental processing, then you might suggest something like automatic writing, where you just write nonstop without editing or turning back, or mandala drawing. These are actually two mandalas that I made. Like I said, part of this involves doing your own personal work. And one way that I've been doing that is through holotropic breathwork training. I've done about 10 holotropic breathworks throughout this process to kind of help support me in doing this professional work. And this one on the top is the first mandala that I drew. And then by kind of using this as a part of integration, it's been a very meaningful process for me. This is the most recent one that I made, and you can kind of see how really working this process of integration, coming back to it, really starts to open up these new channels. And now, I had never really sort of considered myself as an artistic person, but I'm really proud of kind of the mandalas that I've been drawing, and I hang them up and I look at them and I kind of think about what they mean for me. So integration can really be something that's very beautiful, and maybe even the most beautiful part of the journey is how you kind of make sense of it and hold on to it. Yeah, so I just wanted to briefly come back to what the landscape looks like. We're sort of done with talking about the ketamine treatment. On the right here is all the different drugs that are on the pathway to FDA approval. And probably in LA, you might have friends or patients that are really, turning more towards these expanded state experiences, towards psychedelics to deal with their mental health issues, and sort of turning away from the mainstream of psychiatry. And right now, it's a very strange landscape. There's a very kind of wild feeling about how the underground work is being done. I think there's a lot of people that are doing great work in that way, and there's a lot of good healing that's being done, but there's also a lot of boundary violations and professionalism issues and ego inflation and spiritual bypass. So I think it's kind of important for, academic institutions to not just kind of ignore what's happening, especially in a place like LA, where it's really kind of ground zero for this movement. I think the medical model is important, just looking at the effects of what these substances actually are and what they do. to the body. But I think hopefully through this talk, you can see that how important it is to also look at the therapeutic container, that that's a necessary element of working with these substances. You really need that to be opening up into something that's healing versus something that is re-traumatizing or dangerous. And this is a new way of practicing psychiatry, and hopefully, we can move more into a change in our culture where we really incorporate the wisdom of experts that have been working in this way. So yeah, that's my talk. Thank you so much for listening. Yeah, this is my contact information. If anyone has any questions or is interested in learning more about setting up a ketamine practice or working with ketamine assisted psychotherapy.
Thank you so much, Dr. Lochte, for an incredible, interesting talk, really wonderful overview that's clinically relevant in this area, both for our faculty, trainees, and also for our patients who, as you said, are starting to seek these treatment modalities. I have a few questions that I'll share from the chat. I'll just move through them. I think we will have time for them. The first is, given the increase in neurogenesis, are there any studies on use, or I would say promise, for use in mild cognitive impairment?
I don't know too much about that, to be honest. I think it would be a really interesting place to explore. Yeah, there may be maybe other people here would know more about that. I might not be the best person to kind of be speaking to like what's the most up-to-date research in what we're finding for ketamine. There might be other people that are better at describing that. I'm not that I'm aware of, but I think that's an interesting idea.
Hey, thank you. Next question. Is there a difference that you consider between alcohol versus drug or other substance use in your concern and risk assessment for recommending or advising on ketamine assisted therapy?
Sorry, alcohol or
Versus drug. Alcohol versus drug is the question.
alcohol versus drug. Well, I mean, I think you would want to look at each, the drug that they're coming in with. I think there's sort of different risk benefit concerns with different types of drugs. I mean, I think people that have a history of alcohol use disorder, sometimes you want to be a little bit more cautious of maybe bipolar being underlying it because those go together so frequently. But I mean, I would sort of in general think of them in a similar way, but you want to sort of take it case by case and look specifically at what's going on with that individual patient.
Thank you. Yes. And you had mentioned, of course, somebody who has a known history of psychedelic misuse or this vulnerability or unstable in their recovery, that could apply to either as well.
Yeah. And I would still put those people that just in different modalities,
Yeah, exactly. And also it's that informed consent discussion and really teasing out the individual risk and benefit. Great. The next question is, can you say a bit more about your experience using flotation tanks, sensory isolation? Have you used them as a preparatory experience or as an alternative to ketamine-assisted therapy? What successes or failures have you seen with this approach?
Let's see. I haven't actually I've personally used isolation tanks. I think that they're a really interesting modality. I think it takes some maturity to do flotation tanks. It's kind of boring. You really have to sit with yourself and be able to work with your own internal experiences if you're going to go into a tank for like an hour or two or three. I think they're something that I definitely would recommend. I haven't used them personally clinically. I would more just think of them if a client is kind of interested or does work in that type of way. I do recommend breath work. Breath work is the thing that I recommend most to people that are interested in expanded states because I think that is something that people aren't really aware of and can really open people up in a way that's very unexpected. While isolation tanks oftentimes can feel very meditative, sort of maybe a range of expansion that they kind of feel that they might have access to in a meditative state. So I usually mostly recommend breath work to people, but I'm a big fan of isolation tanks. I just haven't talked with people specifically about that, and I don't know outcomes for it. But I would imagine that it would be really helpful if people are willing to do it.
Okay, thank you. Another question. You had mentioned adolescent treatment. Many medications are used off-label with adolescents, but with this class of medication, what additional considerations do you have around special parental consent and adolescent assent?
Yeah, that's a good question. I actually don't work with adolescents in my private practice. I don't feel comfortable doing that. I have worked on a few adolescent cases when I was working in that ketamine clinic, where there was a bit more structure and supervision, and the therapists were familiar with working with adolescents. I was sort of more assisting in those cases. So yeah, there's additional considerations that you want to have around working with adolescents, but I haven't really worked with developing a consent process for that in particular myself.
Okay. Any insurance coverage that you're aware of for ketamine-assisted psychotherapy?
Yeah, this is a really important idea. I mean, insurance is such a big factor here, something I didn't really get into, but such a logistically important concern. A lot
Hmm.
of personal insurance, malpractice insurance does not cover ketamine. The major insurance companies are kind of having additional underwriting things developing around the use of ketamine because there have been, falls and issues related to its misprescription. HAP, CAP, the insurance provider, is the one that I use, and I think that one's actually pretty friendly towards the use of ketamine. But you need to talk with, I mean, UCLA, you might be is kind of open to outpatient prescribing of ketamine because they're self-insured, but if you're trying to find your own insurance, you have to work with your provider and see what they want from you to be able to insure you for this kind of work. Generally, they're more okay with you doing it if you're there with them in person than if you're prescribing it for home use or doing video therapy. So that's what I've seen.
Okay. Is there more you could say about how you assess if a person is really ready for a deep psychedelic experience with a high dose of ketamine?
Um, well, I mean, I think I spoke to a little bit just the basic things that I would look for in the psychotherapeutic process if they're showing kind of that responsibility and maturity to kind of enter into that. I wouldn't jump into a deep session of ketamine. I'd first start with the low dose of ketamine. That's one thing that's nice about ketamine is that you can kind of take baby steps into it. It's unique, with MDMA or psilocybin or LSD, you're kind of jumping in the deep end for a 6+ hour long experience. It could be more than you bargained for. Well, ketamine, it's going to be an hour, and especially with the lower doses, you really don't blow people out of the water initially. So I wouldn't start with a high dose. I would start with a low dose and see how they tolerate it, and then kind of work, gradually work your way up into a sweet spot of what's going to be beneficial for them.
Okay, I think we have time for just one more. Could you speak to the tension between the medical model with prescribed ketamine like Spravato with indefinite repeated use and this model that you're describing around a focus on discrete expanded states with integration? Do you think of each model fitting better with certain presentations or work for different people at different points in their treatment course?
Yeah, I really, really like this question. I think this is super important right now. I mean, I think that there is a lot of value in the medical model of ketamine, especially logistically, to get insurance to approve it, trying to do psychedelic, ketamine assisted psychotherapy is, expensive and resource intensive. And, that's just not something that's possible for a lot of people. So I think the medical model serves right now as something that's sort of good enough. That fits in with sort of insurance requirements. Some of the concerns around Spravato or that, the idea is that maybe the dose is a little bit too low for the really beneficial effects. Yeah, there's a very variety of opinions on this. I think that maybe people that would benefit from Spravato is if that's the options that they have available, then it might be worth giving that a try. You just want to be cautious about, there isn't a therapeutic container as much with that. There's kind of more of a medical container and even a stricter medical container, but you just want to be mindful that hopefully they're working with a therapist or someone that can kind of provide some looser therapeutic container around that type of experience. Yeah, I don't know if there's a tension between the two. It's just there's sort of different schools of thought. Some people have a much more medical view on patients will have a much more medical view on what they're seeking treatment for and what they need out of it. And I think they will seek out the medical model more than this psychotherapeutic model. So I think it's a little bit self-selecting, and that's what's interesting right now is there's a lot of different ways of doing this, and we get to kind of see what's working, and what's working best and what's working in the safest ways, and kind of try and be as well informed as possible.
Thank you. We are out of time today. Anyone else for whom we didn't get to your questions, feel free to reach out to Dr. Lochte directly. His info is here. And this concludes our grand rounds. Thanks everyone for coming today.